Good evening, everyone. And first of all, I would like to apologize for the wait tonight. We have had a little bit of technical difficulties. Dr. Rocia was traveling from Spain to Chile. She got held back in Spain, where she'll be joining us from tonight. And there seem to be some connection issues from the hotel that she's at. But thank you so much for waiting for us in the waiting room. We're going to start. My name is Celeste, and I'll be your host tonight. Just briefly, the proceedings for tonight will be Dr. Rocia will do her presentation, and after that, we'll have a question and answer session. As you know, this is a rerun of our presentation that we did earlier in the month, and we had such an overwhelming response to have Dr. Rocia back soon. So thank you so much for being available, Doctor. I know you're traveling all over the place, and we really appreciate you being with us again tonight.
Thank you, Celeste. For me, I'm so happy to again your invitation, and I want to talk about all these new philosophy that it's biomimetic, and what is the difference to use this new generation of glass ionomers with strontium. This is what we are going to talk about today. So thank you for invitation, and I will start. It's okay?
Yeah, that's perfect. I'll stay on so we can see the presentation is sharing correctly.
Great. Okay. It's okay, Celeste?
Yep, I can see the presentation. Thank you, Doctor.
Thank you, Celeste. So I will start. Thank you so much, doctors. I am so glad to be today with us, and I will talk about this new concept about biomimetic. What means biomimetic? It's mimic the nature. So we're going to talk about biomimetic and what kind of materials are great for biomimetic. For example, right now, the new generations of glass ionomers that have strontium. This is bioactive biomaterial that will work great for minimal invasive dentistry if we are working in dental caries, or if we are working in a molar incisor hypomineralization. So today I will talk about this new generation of glass ionomers, and I will talk about silver diamond fluoride with the smart technique. So it's this combination that first applies the SDF and then applies a glass ionomer with strontium. So my name is Rocia Lasso. I am postgraduate program in pediatric dentistry in University of Peru, Cayetano Heredia. Right now, I am professor of the postdoctoral pediatric dentistry program in Peru, in Científica del Sur University. Okay, and I am clinical director for Special Smiles by Special Olympics in USA. I did an internship in pediatric dentistry in University of California, San Francisco. I have 3 awards of research in this in Peru for Hipólito Unanue Institute. And I am invited for many lectures in countries in America, in Europe, and right now in Africa. But one of my special invitation was here in Spain, that invited to me to talk about this new concept of biomimetic for dentistry. Invite to me the Royal Academy of Medicine and Related Science in Galicia, Spain. No, so this is to that you know a little bit about me. I am from Peru. I don't know if someone visits Peru. Peru, it's in South America. It's a country so rich in because it have the new wonderful of the world, that it's Machu Picchu, that it's great. No, so I invite to visit Machu Picchu. No, it's the new wonderful world. And okay, I will start. What we are going to talk about, what are going to be the topics that I'm going to talk about this night. First, what means minimal invasive dentistry? Right now, we are listening so much about minimal invasive dentistry and about no dental aerosols, that it's so important. Then, what kind of materials work perfect in minimal invasive dentistry? I will talk about the SDF, how arrest caries, and remineralization. And another topic will be the biomimetic. And I will talk about bioactive glasses and about the strontium modified bioactive glasses that is inside this new generation of glass ionomers. And the last thing I will talk is about the SMART technique, that is first applies SDF and then applies a glass ionomer with strontium. Okay, knowledge is powder, of course. Knowledge is power. Sometimes we try, to do our best efforts for have the best results in the treatments. Okay, but if we don't know what is happening in these caries, in enamel, in affective dentin, or in hypomineralization, no, what is happening? What is happening in that histology of this kind of tissues? So know what is happening is power. Why? Because if we know what happened histology, we are going to select the best materials for this treatment and have the best results. So why I present this picture is because knowledge it's powder. Okay, first we're talking about minimally invasive dentistry, and we are talking about this minimal invasive dentistry in the last year because why? We have this virus that it's the COVID-19, and for be safe, in our dental office, recommendation is no use aerosols, no drills. So if we're thinking in not use drills, what is the best treatment? Minimal invasive dentistry will be the best option for no used drills. Okay, what is happening when you use drills? Okay, the aerosols and the designation of the virus. What we are doing for protection, they use the face shields, no, because we don't want to have any problem and no dangerous about it. Okay, but more than don't use aerosols, the philosophy of minimal invasive dentistry is more than don't use aerosols. The first thing is detection of early caries lesion. This is so important. Detection early caries lesion. The second thing is prevention and caries risk. And the third is minimally intervention. The fourth is arrest caries. And the fifth is remineralization. Okay, why is important the early diagnostic of the caries? Because, okay, if we are looking and we are not using loops, what happened? maybe you have a little confused if these patent features are with caries or without caries. So to use this minimal invasive treatment, first thing is use loupes. Loupes are the best for detection and diagnostic caries. So right now, with this picture, look here. This is early lesion caries, early caries lesion here, and it's important. It's important to look well to a good diagnostic. What happened in the proximal caries? It's important to take X-rays, important Baldwin X-rays for detection of caries lesion. Okay, what's another thing that it's good in when we were talking about minimal invasive dentistry? The selective removal of the caries tissue. If we were talking about enamel, it's important to know that you can remove the caries only with dentin spoon. Okay, not with drill, only dental spoon. Okay, and if we have caries in dentin, it's so easier for diagnostic. No, it's so easier than so often the mothers call to the office and said, my kid have caries. Yes, it's so easier. The important is the detection of the caries in enamel. Okay, in the early caries. So to talk about select remove of caries tissue in dentin, no, it's very, very important right now. You can read in the systematic reviews that suggest that the less invasive caries, no, the less remove of the tissue, okay, and only remove the infective dentin, it's less the risk for pulp, for problems with the pulp. Okay, so how we're going to do it, this selective remove caries tissue? Okay, first it's important to note that the soft zone is the infective dentin, and the firm zone is the affected dentin, and the hard is the sound dentin. Okay, what happened in the infective dentin? The infective dentin is the irreversible deterior, and it's impossible doing remineralization in infective dentins. It's impossible. So it's important to remove so well all the infective dentin. Okay, why? Because in this infective dentin, we are going to have bacterials, the organic matrix degradation. So it's important to remove. Why? Because if we have organic matrix, okay, the collagenous fibers that are degraded are not going to be good for remineralization. So it's important to remove all the infective dentin. Sometimes we have like little problems for know if you remove all the infective dentin and if you are working in affective dentin. No, so you have a little problem. Look here, what's the difference? The difference is the color. Affective dentin, it's more light, no, like a light brown, and infective dentin, it's more dark. So this is important to pay too much attention. No, a good recommendation, for example, is to use this chemical remove that's called bricks, for example. They can help to you because it's going to only remove the infective dentin, no, because this kind of removal chemical carriers only remove the organic degradation, these collagenous fibers that are degradations. It's why you remove with the bricks, for example. Okay, so it's important to remove all the infective dentin because we are going to work in the effective dentin. And the effective dentin is the bio-friendly tissue. And why is the bio-friendly tissue? Because it have the same characteristics than a sound dentin with only one difference. And what kind is this different? Is that in these effective dentins, you have more organic matrix, more collagenous fibers. And it's important to have more kind of organic matrix will be so important if we are thinking in use bioactive biomaterials. Okay, then I will talk more about it. And okay, this effective dentin is great, it's a bio-friendly tissue, but what is the big problem with the effective dentin? Is what kind of material we are going to apply in this effective dentin. If we are thinking to work with, for example, with resins, sometimes you will have many failures. It's the same with the glass ionomers, but the classic glass ionomers. So let's check this systemic review. This systematic review show the difference of the difference of the successful of the treatment. It's so big, the difference. In primary teeth, it's 24% to 96%. And in primary and in permanent teeth, it's 43 to 98. So it's a big difference, no? So why your treatment will be in the 96% and not in the 24%? So let's think about it. And what is the problem? Why the classic glass ionomers doesn't have the 100% successful? Why? Why is the problem? Because all the time we listened, no, that the perfect material for effective dentin is glass ionomers. But if it's the best alternative, why you have this kind of difference, no, in this systematic review of 20 years, it's checking the difference of the successful. It's very, very big. So why? First one, remember that when we were talking about enamel, non-hydroxyapatite, it's 97%. And if we are talking hydroxyapatite, how much hydroxyapatite we have in dentin? It's 70%. Okay, it's less in dentin than in enamel. So it's important to know the chemically of this hydroxyapatite. It's the mix of calcium and phosphate. But what happens when you have these acid attacks that come from the plague and from the food? You are going to lose calcium and phosphate ions. So this demineralization. So demineralization, it will be our problem because we are losing calcium and phosphate ions. Okay, so let's check what happened in demineralization. Okay, broken the hydroxyapatite and it's not mix the calcium and phosphate. So what kind of materials can help to again mix the calcium and phosphate? If we think in the most popular material for remineralization, we were going to talk about the fluoride. So the fluoride ions, it's coming, no, and mix with the calcium and phosphate, and formate the fluorapatite. But what happened if we didn't have the 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 good accounts of calcium in this tissue, in this affective dentin? Because remember that the difference of affective dentin and sound dentin is that are more accounts of organic material and of course less calcium and phosphate. That is the tip that happened. Why the glass ionomers doesn't work well in affective dentin? Why? Because now we don't know exactly what kind of accounts will have in the affective dentin. Okay, so this is why it's not working so well, glass ionomers, because depend of how much calcium and phosphate are in the affective dentin. Why? Because fluoride needs calcium for fluoride formation, for fluorapatite formation. So what needs glass ionomers to have good results in dentin? First, good accounts of calcium, interaction with fluorate and calcium ions, and for fluorapatite crystals. That's what we need. No, this is the tip for the best successful in treatments in dentin. And what happened with resin? Why resins doesn't work well? Okay, doesn't work well for this reason. Remember about matrix of metalloproteinases in dentin. No, okay. In dentin, you will find matrix of metalloproteinases, and these metalloproteinases are sleeping. And why? Why? Or what kind of thing wake up metalloproteinases? That acid that are present in adhesive system, or phosphoric acid, or maybe the outside adhesive. No, it will be like a big problem because okay, what happened? They're going to wake up metalloproteinases, and these are going to degradation. No, this zone that is with the adhesive, and of course you're going to have these problems that you have secondary caries. No, in these treatments. So I read a lot of research, and this makes me too much attention because the last year Dr. Domenico Ricucci said, okay, select remove caries is not a good option. It's not going to work well. You're not going to have a good treatment. But the problem is not the technique. The problem is what kind of material you will use it in this affective dentin. And look, the results, okay? It's the same results at the case report that I show you in with resin. Because what happened? Remember the metalloproteinase? Look here, this X-rays is the same looking as these X-rays. And why? Because in this case, used in effective dentin, the selection of the material was resin. And remember, resins are going to wake up metalloproteinases, and this will degradation the adhesive. Okay, so these are going to open our minds, no, to know well the selection, what kind of materials work great for minimal invasive dentistry, especially when we were talk the treatment in affective dentin. So it's different to talk about caries in enamel or caries in affective dentin. Conclusion is no resins fillings in affective dentin to have good results. Okay, I only talk about caries, but what happened with this new problem that we are with right now we have in our in our dental office? This big problem. And what is this big problem that we have every week in our dental office? Is the molar incisor hypomineralization. Is the new challenge in pediatric dentistry and restorative dentistry. Okay, it's crazy. It's crazy when we diagnostic a patient with MIH. And why? Because this kind of patient ask the aesthetic. Aesthetic is so important to them. And the other problem is that this enamel has less account of calcium ions, so it's going to be porosity, and it's going to broken so fast, so easier. Only with the occlusion forces, when they are chewing, can broken their enamel with MIH. The other problem that we have in this MIH is the hypersensitivity, okay? And the last problem is the adhesion. So let's talk about what happened in histology in MIH. Okay, first, this kind of enamel has a deficient in minerals of 20 to 25%. Okay, because it's so much porosity, less calcium ions, will broken so fast, and it's coming caries in this zone. Okay, what another problem we have in molar incisor hypomineralization? It's talk about that in dentin, the dentin of enamel with molar incisor hypomineralization, this dentin has more interglobular dentin. And the interglobular dentin is the slightly less mineral site. So pay more attention, because you will have bad adhesion in enamel and bad adhesion in dentin. And if you use it, for example, the classic glass ionomers, no? Why are not going to work well in molar incisor hypomineralization? Why? Remember what happened in affective dentin and glass ionomers? What needs glass ionomers for successful in the treatment? Needs calcium. And the enamel and dentin of molar incisor hypomineralization is less account of calcium. So the fluoride that is in this glass ionomer can mix with the calcium and form fluorapatite? No, because we are not going to have the good accounts of calcium. That's the reason that it's not going to work well, these materials in hypomineralizations teeth. Okay, so you can compare like a little bit that affective dentin, it has the same accounts of calcium than enamel that have hypomineralization, and try to think in that. You need to give more calcium to this tissue, no more fluoride, more calcium. Okay, so what kind of materials are working great in minimal invasive dentistry. We have two great materials. One is the SDF, and the other are the bioactive biomaterials. So let's talk a little bit about SDF, okay? So SDF is great for minimal intervention, arrest caries, and remineralization. So it's a good alternative in minimal invasive dentistry. Another great material are these new generation of glass ionomers that have strontium. Strontium, and why? Why is I am talking about a lot about strontium, and all at the time I repeat the word strontium and strontium, because remember what needs the classic glass ionomers for remineralization needs that the fluoride mix with the calcium. But if you don't have good accounts of calcium, you are not going to form fluorapatite. This kind of new generation of glass ionomers doesn't need the calcium in the tissue because this new glass ionomers has strontium. And why is it important to have strontium? Because strontium is an alternative to the calcium. So if you don't have calcium, don't worry about it because this new generation of glass ionomers has strontium, and strontium will work great, and it's going to be the same as calcium and can mix with the fluoride and mix with the phosphoric. Sorry, it's going to mix so well the strontium with the fluoride and form strontium fluorapatite. So in this, with this kind of glass ionomers, you don't need to have good accounts of calcium. This is so important. So this is why this material is a bioactive glass. Okay. And the last technique is the SMART, that it's the mix of applies first SDF and then restorative with a glass ionomer with the strontium. First, I'm going to talk about SDF 38%. SDF, it's right now using a lot in the United States. You are going to listen webinars about SDF. And why? Why right now SDF is a good alternative, and you listen more about SDF and suggest to use more SDF. First is because it's approved these SDF the 2015. No, it's approved with the FDA approved the SDF like desensibility. I work in this research that helps the FDA to approve the SDF to be introduced in the United States, because we are not going to have any problem in use it in humans. So, okay. What is the composition of the SDF? It's silver ions, aluminum, and fluoride. Okay? What is the difference when we compare SDF with a fluoride varnish? The accounts of the fluoride, it's so different. It's, if you are looking, it's double. It's double accounts. And a fluoride varnish doesn't have silver, and it's so important to have silver because it's good for kill bacteria. So the fluoride can kill, but a little bit, not at the same that can kill with the silver. The The American Dental Association suggests that one of the best materials for non-restorative treatment is SDF. It's better than the fluoride varnish, is better than Recaldent, so it's the best alternative. And this is the no restorative caries control, cavity control. We have this case, the caries is only in enamel, so you don't need to remove nothing because it's in enamel. It's you don't need to use a dental spoon for remove. You only applies the SDF and will work great. Look, this follow-up of 12 months. It's perfect. It's perfect. The penetration of SDF in enamel, it's so good, and you can remineralization enamel will be good. Okay. What happened with the what problem we look when we were using SDF? The color is dark, okay? But right now we have Rivastar, and Rivastar mix the SDF and then applies the Chi-I, that you are not going to have problems with the color. Look here. Okay, it's dark, but not so dark that if we only use SDF. And if you applies in healthy pit and fissure, you are not going to have problems with staining the pit and fissure. You are not going to have problems with the color. Okay, look the penetration that you will have it if you are using SDF in pit and fissure. It will be better than use a sealant, okay? And why? Look the penetration. It's going to penetrate all the pit and fissure. And what happened with these caries that are proximal caries? We have this case that is only in enamel. Look here, only in enamel. Check this second primary molar. This lesion, it's only in enamel. I took the decision of use SDF for arrest these caries. And look the follow-up. Look the follow-up of the 6 months. In 6 months, it's done the remineralization. Look here. I use it in this case SDF and Chi-I to don't have problems with the color, and the remineralization is great. This is another case, okay? I took X-rays and I am looking this caries lesion in proximal surface, okay? I put orthodontic separations. So the next appointment, I can use the SDF in 2 ways. One, with the floss, you can put the floss and apply the SDF, or maybe using this micro brush. This micro brush, it's great for proximals lesions to treat the treatment with SDF. Look here, this microbrush, it's in SDI, so you can buy it, or you can use this dental floss. After applies the SDF, I applies the Chi-I for don't have problems with the color. So finish the case, it's remineralization. And what happened when the caries is indenting? If we decide to do a no restorative cavity control. For example, look this case, the X-rays show to us that the lesion caries is indenting, okay? Applies the SDF and look the control, the follow-up of 12 months, It's remineralization, these caries in dentin. Let's check the X-rays. And here, this is the pre-treatment X-rays, and look the lesion, the caries lesion in dentin, and look right now the lesion, it's remineralization. Okay. What happened in dentin? In dentin, it's better penetration than in enamel. That is why it's so good. Okay, again, I will talk again about metalloproteinase. Metalloproteinase that are present in dentin, in sound dentin or in effective dentin, will you can wake up, no? The metalloproteinases that are sleeping if you applies, for example, orthophosphoric acid, okay? So the silver that it's present in SDF works great for inhibition of this enzymatic, that is the metalloproteinases. So it will be perfect. Okay, we know right now that the penetration in enamel is good, but it's better the penetration in dentin. And this is why this systematics review suggests that if you want to remineralization enamel, use it for fluoride varnish. But if you are working in effective dentin, it's better the SDF. This systematic review suggests that. And no problems, okay, with the dark color. And this is the smart technique that it's good, the adhesion of these glass ionomers when it applies in a cavity that you first applies SDF. No, so the adhesion for the smart technique is great. And this is why I'm talking about the colors, and don't worry about these dark colors. This is the same patient. In the upper, I applies SDF and then Chi-I, and I close the cavity with a glass ionomer, this white glass ionomer, for that it will be good for don't look so much dark, the molar. But let's look when I use it only SDF. Look these dark zones that are around the filling. But don't worry about what is looking. The most important thing is the remineralization of this material. And look, this case, the follow-up 6 months, everything works well. 80 months and everything is working great. Okay, what's another alternative for using the smart technique? If we are working in dentin, the best is SDF and then applies glass ionomer. But if you are using the smart technique for enamel, you can use it SDF and resin. Okay, and you will have great results. For example, this one. This is a caries that it's only in enamel. Applies first SDF and then applies the Chi for the color. Then applies this adhesive, this universal adhesive. Please don't apply orthophosphoric acid to the SDF. Don't do it that. But it's good if you apply this universal adhesive that has fluoride and MDP, and will work great in this case. After using the universal adhesive and photopolymerization, you can use a fluid composite, no? That the name is Aura Easy Flow. It's great. For me, it's great to talk in pit and fissures that I know that I have a early caries lesion. Look here, good looking, no problems with the color, like a little bit, no, but not a big problem. Okay, so I'm talking that the color is not the problem with the SDF. The problem with the SDF is the high penetration of this. This high penetration, be so careful to please don't use it so close to the pulp, okay? You can use it as the F in dentin, close to the enamel, dentin in between the in the middle. If we maybe imagining that you cut in 3 parts, so the part that it's close to enamel, you can use it well as the F. The middle part, great. But the part that it's close to the pulp, please don't use SDF because you will have these problems. You're going to necrotic the pulp. So let's check this case. And this picture I like to show because show to us how is the penetration and why is necrotic the pulp, no? So what kind of alternative you will have if you are close to the pulp if you can use SDF? The biomimetic materials. So if we talk about biomimetic materials, I will explain what means biomimetic. Biomimetic means to copy or mimic nature. And what will I mimic? What I'm going to imitation? I will mimic the bio-mineralization. And what means bio-mineralization? All the tissues that are rich in minerals, rich in hydroxyapatite, as enamel, dentin, bone, cement, to be so rich in minerals, first needs for this development needs the presence of organic matrix. These organic matrix are going to crystals the calcium and ions phosphate and crystals to hydroxyapatite crystals. Okay, this is the biomineralization, and this is why are going to mimic in biomimetic this bio-remineralization. Okay, perfect. The first, this biomimetic philosophy, it's not new. Look, doctors are working years before dentistry. Dr. Larry Hinch in the 1969 developed this new glass, this new bioactive glass that its composition is calcium silicophosphate glass. And let's check what is going to work well this material. Let's check this video.
Human beings are fragile. Accidents, injuries, traumas. The human body can regenerate itself, but sometimes it's not enough. Implants, prostheses, and substitutes are often necessary to rebuild osseous structures and help the body to regain its functionality. Bioactive glass contributes to bone growth. It can be used in a wide range of medical applications. Like here, in the case of bone filling, the material is put into the bony defect. Just a few hours after the implantation, ionic exchanges occur between body fluids and bioactive glass. A biological fixation is created between the biomaterial and host tissues, leading to a solid grip within the osseous site. This fixation becomes a silica gel and gradually mineralizes into a calcium phosphate layer, The composition and structure of this layer are identical to human bone. The fact that silica and phosphate concentrations are increased around the material causes a genetic activation, which induces a differentiation and proliferation of osteoblasts. These osteoblasts are the actors of bone remodeling. 100% synthetic, therefore 100% safe, bioactive glass is biocompatible and bioabsorbable. All its bioactivity lies in its ability to transform itself and, in the end, to become completely assimilated by hosts. Hosts, or rather, human beings.
Okay, with this video, we start to understand how work these bioactive glasses, okay? So for work these bioactive glasses in biomimetic, the biomimetic needs to mimic biomineralization, and this we're going to call bio-remineralization. Bio-remineralization is different than remineralization. Right now you understand that. So for this, to mimic well this biomineralization, we are going to need bioactive biomaterials. And what means a bioactive biomaterials? These materials stimulate the regenerative engineering of the material and tissue interface. So it's great for use biomimetic in dentistry, especially in the minimal invasive dentistry. It's great to use this philosophy of biomimetic to mimic the nature doing the bio-mineralization. Okay, so I will talk more about it. So if we are talking about enamel, the enamel are formed with prism, and the prisms are formed of hydroxyapatite crystals, and the hydroxyapatite crystals are formed for calcium and phosphate. Okay, great. So how is the development of enamel? We are going to have the cell that we need for development the enamel. We are going to need ameloblasts. These ameloblasts are going to produce calcium and phosphate. In the first moment, these ameloblasts are going to be cubic, and then are going to be large and start to secrete the secretion of a protein called amelogenin. What is important to know this protein called amelogenin? Because the amelogenin will going to transportation, it's going to transportation the calcium and phosphate to the organic matrix, and these organic matrix are going to crystals to form hydroxyapatite. So when happen that, it's called mineralization. The mineralization stage is this. After the mineralization stage, we are going to pass to the mature stage. And in the mature stage, what happened? Amelogenins are going to be resorbed by the ameloblasts, and then ameloblasts are degraded, that's disappearing from the enamel. So when we were talking about a mature enamel, we are not going to find ameloblasts. No ameloblasts in the mature. So this makes to us to pay attention, because if I talk about biomimetic, and the biomimetic is mimic the biomineralization, we need a good account of organic matrix. And what happened in enamel? We are going to have 97% of hydroxyapatite, and only the organic matrix will be this 1 to 2% of amelogeninase. The protein will be the part of the organic matrix. And that's sometimes it's not going to work so well biomimetic in enamel. It's going to work well if you give some bioactive biomaterials as nanohydroxyapatite that will be attractive by the melogenes or are present in the interplasmatic zone, and these will crystals and form new crystals of nanohydroxyapatite. This is what happened in enamel. It's different that what happened in dentin. Dentin, you have more organic matrix. You're going to have more organic matrix than the enamel. So it will be great because in this organic matrix, you will find a high numbers of bioactive regulative molecules. And what kind are proteins? A lot of proteins, not only 1, 2, or 3 proteins that you have in enamel. Here you have a lot of proteins. And what is the role of these proteins? The role of these proteins is that when odontoblasts produce calcium and phosphate ions, these are going to do the transportation to the matrix, to the organic matrix, and crystals, this organic matrix, calcium and ions, and form hydroxyapatite and mineralization, the dentin. Okay? So what kind of materials are so good for biomimetic, mimic, and bio-remineralization? What are the best materials? Are the bioactive biomaterials. And this is all the bioactive biomaterials. You have the NEO-MTA, you have the biodentin, both are bioactive glass. And you have another option that is the nanohydroxyapatite, okay? That it's so good, this for enamel, okay? Glass ionomers are like NEO-MTA and biodentin work so good in dentin and in pulp. And hydroxyapatite will work great in enamel. And you have a third group of bioactive materials, the enamel proteins. There you have the nature that the name is endogen, and the synthetic proteins that it's incurodon, peptide also selfie, and these materials. What is important? Do you remember that I talked that in enamel we have a little problem that we have little accounts of amelogenin? This is to put more to apply more amelogenin, and you will interaction with the calcium and phosphate, and you can do it a good bio-remineralization in enamel. So it's an alternative. But today I'm going to only talk about bioactive biomaterials. I'm only going to talk about bioactive glass. And the bioactive glass, it's the NEO-MTA that it's so good. This is the new bioactive glasses. And all the bioactive glasses are for the composition. It's calcium. It's calcium, and this needs hydration. No, the first bioactive glass that are used for dental is the MTA, and was approved for FDF in the 1998. Okay, so how works this bioactive glass in the effective dentin? Because I told to you that if you are working in dentin, it's great that bioactive glasses. So I will show to us how work this bioactive glass. Look here, this is the collagen of fibers. So when you apply bioactive glass, for example, NeoMTA2, okay? They're coming, these bioactive glasses, and adhesive so well to the collagenous fibers. Okay, so let's check this video. Here is the bioactive glass. When it's in the collagenous fibers, what is going to do this bioactive glass? They are going to give a lot accounts of calcium, because this bioactive glass composition is calcium. So we'll give a lot of counts of calcium. And remember, you don't have good accounts of calcium in affective dentin. So it's important to give calcium to this tissue. When you give a lot of counts of calcium, what happens with the pH of the zone? The pH will be more high, it will be alkaline, and it's perfect because you're going to inhibition the growth of the bacteria. So first, you have a lot of counts of calcium that are coming from this glass, bioactive glass, and these activate the proteins that are present in dentin, and the proteins wake up the odontoblast to form again calcium and phosphate. Form calcium and phosphate, these proteins transport the transportation of these new calcium and phosphate ions to the collagenous fibers, and the collagenous fibers crystals and have new accounts of hydroxyapatite crystals. So this is magic, no? Remember, you right now don't need that the tissue have a lot accounts of calcium. You will give this calcium. So the biomimetic, the bio-remineralization that you can do it with this bioactive glass, it's great. But let's check in this case report. Look, this second primary molar, okay, looks healthy right now. The treatment was maybe a pulpotomy, no? But let's check the preoperatory x-rays. Internal root reabsorption. So what is the alternative if you have this case in your dental office? Extraction. With the bioactive glass, don't think in extraction. You can regenerate this tissue, this defect. And how? Using a bioactive glass in this treatment. What is the treatment? The treatment is the LSTR treatment. First, you need to open the pulp chamber, add a triple paste, know that it will form for metronidazole, ciprofloxacin, and minocycline, and applies in the floor of the chamber, for 3 to 5 days. And after that, remove all these antibiotic triple paste and applies the bioactive glass. And look the results. After 9 months, you check, repair this internal reabsorption. 80 months, the follow-up great, and 24th follow-up, you have the first permanent. So it's great. And 30 months of follow-up, great. This is a case that in the first moment, your option is extraction. But right now, with the bioactive glasses, change your mind, okay? And you can do these treatments and save the teeth, okay? Because it's magic, these bioactive glasses, no? It's an alternative. Another thing, Remember that you give this bioactive glass give a lot of counts of calcium and a lot of counts of calcium. What happened with that pH of the zone? Be more alkaline. And this is good for inhibition of the bacterial growth. In affected dentin, you will have Streptococcus sobrinus, mutans, lactobacillus. So what happened there when you apply a bioactive glass? Look here, okay, you this bioactive glass give a lot of calcium, and this calcium will you will have alkaline zone, and the alkaline zone is not a good zone for the growing of these materials. Okay, let's check this other case. Look here, this kid, only 6 years old, coming to my dental office. Mom said, I don't want more treatments for this teeth, please. The other doctor is trying to do pulpectomy, but it's not working. So please extraction. And I said, okay, first I want to know what happened with the x-rays. So I took an x-rays and look, the roots are perfect. This is okay. These zones told to me infection. Okay. The same treatment of the other case. For LSTR, no, the lesion sterilization and tissue repair with this triple paste, antibiotic triple paste, then remove after 3 or 5 days, and then applies this bioactive glass in the pulp chamber. After 6 months, looking, great result, no? Shows 100% repair of this necrotic pulp. After 80 months, everything working well. And after 30 months, start reabsorption, the natural reabsorption, no, the physiologic root reabsorption of this first primary molar. And after 32 months, we decide to do the extraction. And look this great sealing that you can do it with these bioactive glasses. It's great. Another case with neo-MTA, the neo-MTA neo-potty. I have this another case with a fistule, and again, open the pulp chamber as the same of a pulpotomy. First applies the triple paste for 3 to 5 days. After the next appointment, remove all this triple paste and applies the neo-MTA. Neo-MTA is pre-mix. You don't need to mix powder and liquid. It's pre-mix. Look here, after 1 month of control, great. Look the difference in the x-rays. This is repairing. But what's the big problem with these bioactive glasses? The setting time. Sometimes you need to apply the composite 72 hours, no? And this is a problem. But right now it's changing this because we are going to have new generation of MTA, no? That is the neo-MTA, and the other is the biodentin. These bioactive glasses are not definitely treatments. You need to cover, no, to do a restoration after these materials with composite or with glass ionomers. So let's check here. This is a direct pull capping case report. This first primary molar, check the CARIES lesion in these x-rays, and the alternative was to remove the infective dentin. And when I remove the infective dentin, look here, like expulsion of the pulp. So I did a direct pull cupping with this MTA, look here, and then after the direct pull cupping and then restoration with a glass iomer of high viscosity. That is the light cure high viscosity material. That is the Riva light cure high viscosity. Okay, so the idea is this, the same like the video. First, you remove all the lesion caries, and you have this expulsion of the pulp. Don't worry, use this bioactive glass, and then restorative with glass ionomers with resin, and you will have great results. Okay. And the other group of bioactive glass is the new generation of glass ionomers. And the new generation is these glass ionomers that add strontium. So you are going to listen or read about strontium modified bioactive glass that it's present in the glass ionomers. So it's the same. Remember what needs the glass ionomers, no, in dentin for work. They need good accounts of calcium for interaction of fluoride and calcium ions and for fluorapatite crystals. If you don't have good accounts of calcium, you are not going to have good results. Here, with these new glass ionomers with a strontium, forget this problem, because you're going to add a strontium that is similar as calcium. Why? Why is it similar? Look here. It's in the same line. Calcium and down is strontium. So it's going to work great for form the hydroxyapatite. This is strontium. It's known that upregulate osteoblasts and downregulate osteoclasts. The other property is the strontium is also slightly bactericidal, and you can use it great in effective dentin and in enamel caries. Okay, so this is a bioactive glass modified with strontium, and look at the new hydroxyapatites that you will form with this bioactive glass. Great. Good size. And another thing, do you remember fluoride needs an interaction of the calcium to form fluorapatite? Better interaction is with the strontium. Much better interaction, fluoride with the strontium than with calcium. So it will be good to have a strontium in this new generation of black ionomers, because we are so comfortable and we have to use this kind of material, because you forget that if you have calcium or not in this affected pelvis, for example. Okay, this is a strontium fluorapatite. And how it works, I will show here.
It is essential that the glass ionomer is placed while it has a glossy surface. The gloss is free polyacid, which is able to penetrate the cavity surfaces to form a strong, hydrolytically stable chemical bond to calcium ions within the dentin and enamel. In addition to chemical adhesion to calcium in the tooth, a fusion bonding process takes place as well. Calcium and phosphate ions from the polyacid-treated dentin and enamel, and strontium and fluoride ions from the unset glass ionomer intermix and precipitate, forming an interface called the interdiffusion zone. This zone is stronger and more acid resistant than either the glass ionomer or the tooth. The combination of the interdiffusion and the chemical bonding provides the basis for a strong, stable adhesive interface and creates a bacteria-proof seal for the cavity, best described as a chemically fused seal.
Okay, so what kind of glass ionomers has strontium? What kind? Riva. All the line of Riva have strontium, okay? And you have this strontium present in the ion glass technology. No, how much is the percent of strontium? It's 50%. That will helps to us. No, forget calcium, because you will give strontium to this affected dentin.
Riva products contain proprietary glass filler called ion glass. SDI ion glass is a radiopaque reactive glass that releases high amounts of phosphate, fluoride, and strontium ions to assist in remineralizing teeth. Immediately following the placement of the glass ionomer, a ferment of chemical activity takes place under the restorative. Available minerals from the dentin mix with the ions released from Riva, creating a free ion exchange that continues until the acid is buffered by the phosphate ions. As the pH rises, the cement restorative sets and the ion exchange slows down. It has been shown that strontium, fluoride, and phosphate ions from the Riva can penetrate a considerable distance into partially demineralized dentin, aiding in its repair.
Okay, this is the ion glass technology that you will find in all the line of Riva glass ionomers. And this is the picture of the capsule of a Riva Light Cure high viscosity. And it's great. This is one of my favorites glass ionomers because it's modified with resin, and you have a good looking, and the percent that of strontium in this material can help to don't grow bacteria in the in plaque, no, less plaque. Look, this case, this is a caries ineffective dentin. I remove infective dentin and I will work in the affective dentin. It's ready for applies the Riva Light Cure high viscosity. And look the looking of this material. It's so good, the color, and it's a definitely treatment with a good aesthetic. Okay, look, the x-rays, the control, great. This is another case that I used the Riva Light Cure high viscosity. Look, this the follow-up, it's 24 months, and it's great. It's great. Look here. It's another case. If you have caries, no, in enamel, can you use the glass ionomers with a strontium? Yes, but my recommendation is to use it the Riva Light Cure, but not the high viscosity, the Riva Light Cure, and you will have these results perfect in these pitted fissures with early caries lesion. Okay. And in hypomineralization, what was the problem in hypomineralization? That in hypomineralization you don't have the regular accounts of calcium, the same accounts that you find in a healthy or sound enamel. So in this case, what we need to add calcium. But if you don't have calcium, you can add strontium. So a glass ionomer with strontium. This is Riva Protect, that is a pit and fissure glass ionomer that have strontium. It's great for this hypomineralization you find in initial, no? that is in pit and fissures. So you can use this sealant and you can check 2 years of follow-up and everything is working well. Look here, it's perfect, working, the x-rays, 24-month follow-up. And another case of Riva, this is Riva Light Cure High Viscosity. If you are working in dentin, in hypomineralization, I prefer to use the high viscosity because we'll be resist more to the occlusion forces. Look here, its adhesion is great. Look that great adhesion you can have with this kind of materials. And the last thing, okay, we talked that it's so important to add strontium to the glass ionomers, and we have this new generation of glass ionomers that don't need the calcium because have strontium inside the material. But another good thing, do you remember the problem of the silver in the SDF, that the penetration it's so good, and I told that be so careful to talk to apply SDF so close to the pulp. Right now you have glass ionomers with strontium that add silver doubets. Okay, you will have great results with this kind of glass ionomers with strontium and silver. Where you find this? In Riva Silver. Riva Silver, it's the composition is glass ionomer with strontium and with silver. So you can use it so well in effective dentin close to the pulp. Look this case, and I'm going to explain why it's important to use bioactive biomaterials like this new generation of glass ionomers with the strontium. Okay, look this case. Before the treatment before was a resin in an effective dentin. Of course, you're not going to have good results. Look here, secondary caries. So in this case that I'm so close to the pulp, I prefer to apply Riva Silver. Okay. And if you are thinking in aesthetic, no, it's important for your patient, the aesthetic, don't worry. The next appointment, you remove a little of this Riva Silver, and then you can restorative the top with composite, with resin, and you will have aesthetic results. Look the follow-up, it's perfect, 9-month follow-up, and don't worry about that you are using this material close to the pulp because the penetration of this material is not so high because you don't have too much count of silver. Okay, we're going to finish talking about SMART technique. This is SMART technique that means silver modified aromatic restorative treatment. And it's great, this combination, SDF and glass ionomers with strontium. Okay, for the cases of molar incisor hypomineralization that have a high hypersensibility, a good alternative for high hypersensibility is the use of SDF. So you can apply SDF, and after applies the FDS, you can apply a glass ionomer with a strontium, and we will work great for remineralization this song. It's more than remineralization, it's bio-remineralization, remember. So, okay, this is all for today. I want to explain how important it's to know these new materials and to know this new philosophy for dentists that is biomimetic. Biomimetic, mimic biomineralization. And if you mimic biomineralization, you will have great results in your treatment if you are working in effective dentin or in a molar incisor hypomineralization. So it's good to know this. The bioactive glasses are great for dentin, for pulp. And if you are talking in restorative, in definitive restorative materials, are these glass ionomers with strontium. Thank you so much, Celeste. I am open for the questions.
Hi, Dr. Rocia, can you hear me? Yeah.
Hello, Celeste.
There we go. Right, thank you so much for that. You both had a rough start, but I must say, once again, once you get going, your presentations are so captivating that didn't even think about how we started. So thank you so much for that. The focus with this presentation, is to have more opportunities to do non-aerosol generating procedures and to look at new technologies to improve the profitability in practices. And I think you showed them so well, all these tips and tricks yet again. So thank you so much for that. I had a look and I don't see any questions as yet. I think let's give it a minute or so. Delegates, if there's any questions, please put it in the chat or the question section for us. While we wait, I don't know if you've seen the latest copy of the Dentistry SA. We've got the Riva Star on the front. We've got our promotion on the Riva Light Cure and Riva Self Cure. Everything that Dr. Rocia has been presenting tonight with the ion glass and the biomimetic formula, it's in the Riva that we've got already. So that if you buy the Riva Star, if you buy the Riva Light Cure or the Riva Self Cure at 2,400, you get your Riva Star for free. So it's everything you need to do what Dr. Rocia has been teaching tonight. So let's give it a minute or so. Doctor, I don't see any questions coming through as yet. Let's see.
No questions yet, Celeste?
No, I don't think we've got any questions for tonight, though.
I think so. It's clear that this is the new generation of glass ionomers that will helps to the treatment, that good treatment in an effective dentin. Because sometimes we are talking so much about minimal invasive dentistry, no? It's a great alternative. But your problem is which material is the best for this treatment. Yes. And right now we know that these kind of glass ionomers are great. Are great for to work in effective dentin, because know that effective dentin has less accounts of calcium than a sound dentin. So with this kind of materials, you will add strontium that is the same to add calcium, and you will have great results. You're going to mimic, it's a biomimetic material, and you will mimic biomineralization.
Definitely, but mimic what is the natural. So no, it's definitely the future of dentistry. So thank you so much for presenting that again. I think that will be it for tonight. I wish you safe travels, and I'm sure we'll be in contact soon again.
Thank you, Celeste. I hope the next webinar will be in Peru. Right now I'm in Spain, and I have a little problems with the connection. So sorry. I don't know what happened with the connection here in the hotel, but everything now it's working.
With technology, can't live with it, can't live without it. But all's well that ends well. So thank you so much. And I just wanted to say thank you to Michael again as well for sponsoring the webinar. Michael Farrow from SDI, thank you so much for that. And Dr. Rocia, have a lovely evening. We'll chat soon.
So much.
Thank you, and thank you, delegates, for being so patient with us. Keep well. Bye.
Bye. Thank you.